I think one of the things we were anticipating next is what immunotherapy strategies are going to be the next line of success. And the next kind of strategy was adding a CTLA-4 inhibitor to a PD-1 or PD-L1 inhibitor. And so I wanted to ask Leora about, is there a situation today where you would consider doing that, or how do you see the current situation with that strategy?
So right now in non-small cell lung cancer, there's no role for that. CheckMate-227 is still out there trying to answer that question. A complicated 2,000 patient study that we've seen 300 patients here and 500 patients there presented, and changing biomarkers, moving from PD-L1 to TMB. We had a press release that the TMB data was withdrawn from the FDA, not because maybe the TMB high did well, but because also the TMB low patients did well on that regimen. And so it's pretty confusing, but right now in non-small cell lung cancer, outside of clinical trials, there's really no role for nivolumab and ipilimumab.
And we've seen that with the other combination of durvalumab
Right.
and tremelimumab too.
Right, and so at ESMO we saw that durva and tremelimumab was a negative trial as well, and so it did not meet its PFS endpoint, and so.
So I'll ask you and John, I guess, because I was going to turn to John to ask you, is TMB dead? Is tumor mutation burden dead?
I don't think it's dead. I just think that it maybe needs to be redefined. It's the problem with that marker as well is first it was 10, then it was 16, and it was using the foundation panel as a surrogate or versus doing the actual sequencing. So I don't think it's dead. It's just being a moving target of what is TMB high, and can we do blood? There's studies like BFIRST that are out there that had interesting data as well at ESMO. So I think that we're still struggling figuring out what is the best predictor, or that we should give patients IO, and what's a predictor that maybe we shouldn't give them IO. But I don't think it's dead. It's a reiteration.
Yeah, I guess I have a little different perspective on this as regards to CheckMate-227. So it's true that the markers changed during the study, but I think it's important to identify that they were locked before the patients were unblinded. So it is truly a prospective one with a set TMB score. If they're 10, I think the 16 is applying for the blood markers. And I think it's important to acknowledge it actually did exactly what was hypothesized for PFS. You know, it really is pretty striking that there was an enormous PFS, or a very substantial PFS benefit for a non-chemo containing regimen in the TMB high, and in the TMB low, there was actually no PFS advantage. So insofar as the primary or the co-primary endpoint was PFS in the TMB high group, you know, that was a success. But as you said, there is now this interesting finding that the OS benefit seems to extend to the TMB negative, which is interesting. And this really argues that there must be post-progression benefit from getting the combination that you're not seeing from that tumor shrinkage. And I think from my perspective, that's a very intriguing finding, and it suggests that the patients who may be benefiting from this regimen may extend beyond that narrow group.
So John, I wanted to ask you, what should be the message to community oncologists? Because many of them are sending tumor specimens to labs, various labs who will remain nameless, and often that comes back, often on the first page, and it's there, and you know it, and the question is, what do you do with that?
Yeah. Well, so, you know, in 2019, as of right now, TMB is not a marker that's useful for selecting therapies. It may be in the future. One of the ancillary benefits, and in fact, I think in some ways what may turn out to be the greatest benefit, is if people are getting TMB, you're going to find a lot of those driver mutations as an ancillary benefit that people were missing before. That may turn out to be as much, if not more, of a benefit. But it also points out that PD-L1 alone will not end up being the full story. There's other data saying that the genomic markers, you know, may also impact it. So, you know, I think right now, I think the message is everybody should get immunotherapy. We're refining who's going to get the most benefit or who would get the most benefit from combination immunotherapy. But still right now, unless somebody's got an overwhelming reason in terms of autoimmune disease or a transplant, as Heather said, there's nobody that shouldn't get immunotherapy with non-small cell lung cancer, I think.
Yeah, so we've taken, again, second line, standard second line, put it with our first line regimens.
Yep.
Although there are the patients, the greater than 50%ers. You know, I find myself doing monotherapy much more frequently in non-squamous than in squamous. You know, squamous, I think there are still, the data isn't robust in my opinion, and I'm more likely even in a greater than 50%er to use the carbotaxane plus pembro.
The 4-7
yeah,
regimen.
regimen, and so I think that that's true.